Nurse Executive Fundamentals of the Preoperative Unit is our episode topic. Rejoining us as guest for this episode is Noreen Hudson, a registered nurse and BRG's team lead for perioperative services. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Noreen, thank you so much for joining me today.
Thank you. Thank you for having me. I appreciate you taking the time to invite me.
So this episode is a continuation of a series we started back in season 2, episode 4, covering the various different departments that comprise a perioperative services division. Now, in that episode, we covered the operating room, and we also covered sterile processing department in season 2, episode 12, that aired back in June, as well as a combined episode for the PACU, covering both phase 1 and phase 2 recovery that aired more recently. The remaining components, if I remember correctly, are pre-admission testing and the preoperative unit.
Yeah, we have pre-op and we have pre-admission testing. Two separate areas, two separate departments, two separate expectations, two separate everythings.
Okay, then what are we talking about today?
Yeah, so let's talk about pre-op today, and then we can always do another episode if there's interest on the pre-anesthesia testing. So pre-op. Pre-op is your patient's first point of entry to their day of surgery. So they go in, they do the registration, and then registration brings them into the pre-op area. And that's really the area that gets them ready, prepared for surgery. They do the vital signs, height and weight. There may be some last minute diagnostics that need to be run, urine pregnancies, maybe some last minute H&As or coags. But really, it's where we get everyone ready to go into the operating room. Medication reconciliation is done in this department. IVs are started in this department. This is where consents are typically signed. Patients are marked for site marking. So there's three main components of the pre-op area. One is the nursing assessment component. The other is the anesthesia assessment component, anesthesia consent component. And then the last one is the surgeon component, making sure that the H&P is completed and or updated. The patient is site marked, any last questions, any last minute questions the patient may have. So those are like the three components of it. Now, how long is a patient supposed to be in pre-op? We get this question asked a lot. And really, the standard of care is it varies. You should not have a patient in pre-op for more than 90 minutes. And I would argue that 90 minutes on some cases is a bit long. We like to say it should be acuity driven. For example, if you have an ASA1 patient that's young and healthy, maybe a 23-year-old just having a hernia repair, no medications that have to be really reconciled, no past surgical history, no past medical history, you can probably do that pre-op assessment in about 30, 45 minutes. We can bring them in a little bit closer to their surgical time versus a patient who may be a little older, having a more higher risk surgery, say cardiac surgery, vascular surgery, that might have a lot more medications that we have to look at, reconcile, dialysis patients that we might have to do some last minute lab work before they go into the operating room. You might want to bring those in about 90 minutes in advance because it's going to take a little bit longer. Orthopedics patients that need neuraxial blocks, probably going to want to bring them in about 90 minutes so they have time to do that block. So really, we like to see patient arrival times and patient length of stay in pre-op to be acuity driven. So that's why there's that swing there. Where pre-op typically gets into trouble is some places or some surgeons will bring all their patients in at once. They'll have 4 patients throughout the day and they bring them all in at 5 in the morning or 6 in the morning. Now you have patients sitting around, they're unhappy. You have nurses that are unhappy because they're probably getting snipped at by the patients, and you're keeping patients NPO a little bit longer than necessary. Not a good practice to have. We see it quite a bit though. And the reason we typically see it is the surgeons have zero faith in pre-ops efficiencies or ability to get that patient ready in the right amount of time. So instead of addressing the efficiency problem or the smoothness problem or the processes in place, they put a band-aid on it and start bringing those patients in earlier and earlier. Bad idea, not a good practice to have.
Wow. You threw a lot at me. All right, so let's talk about staffing the pre-op area. What's the nurse to patient ratio? How many nurses would you normally see on a unit, and any ancillary staff that should be in that area?
Yes and yes. So we do want to see ancillary staff in there because they are extremely helpful in getting the vital signs, getting the patient undressed, getting SCDs on the patients, getting height, weights, urine collection. So they are really the backbone of pre-op to help make things smooth and run efficiently. We like to see some sort of unit clerk, unit secretary in there because there are last minute phone calls. Dr. Smith, your patient is here. We're waiting for you. What's your ETA? What's your arrival? So they coordinate as like an air traffic controller for us. Super important and really helps get the day started and the day kicked off less chaotic. Now, I saved the nursing to last because that can vary throughout the day. Pre-op is extremely busy in the morning because usually in the morning you have all your rooms starting at about the same time, anywhere from 7 to 7:30. Cases usually are scheduled to start. So all those patients will come in at the same time. So you really have to be careful of bottlenecks in registration because it's not uncommon to have 8, 10, 12, and if you're a bigger place, 20 patients come in at the same time. So that can be a choke point, a bottleneck point, that registration. And then you want to make sure that you can get all those patients ready for that start time. So you want to make sure that you have enough staff to cover that demand. And I'm skirting around an exact number, Nick, because there really is no exact number. I've seen some places that will bring 10 patients in at one time and they'll get them ready with 5 nurses because they are that efficient and the processes are that hardwired. I've seen other places that bring 10 patients in for 10 first case on time starts, and they need 10 nurses because those nurses aren't as streamlined, the processes aren't as streamlined, or it's just a higher acuity facility. So it really depends on what you can do to get those patients ready safely, efficiently, and smoothly. The problem with pre-op is once you get through that first big boom, after that, things trickle and stagger. So you don't necessarily need 10 nurses at 9 a.m. like you would at 5 a.m., 6 a.m. So it can be a very tricky place to staff because you want them here to get that morning rush done, but you don't need as many throughout the day. So what some places do to get around that is if you do have a PACU that staffs 24/7, those PACU nurses can come help out with those first morning rushes. Or you might bring those PACU nurses in, that first shift of PACU nurses in, say about 6 o'clock, 7 o'clock in the morning to help out with that. And then they can just parlay over to PACU after that. So there's ways to be creative with staffing to where you're not bringing so many people in and then you have so many people just sitting around after that morning rush.
Are pre-op and PACU always two different physical locations? Or I've heard
Yes.
of some
Yes.
smaller hospitals out there are doing pre-op and PACU as one combined area. What are your thoughts on that?
They have to be separated physically. It could be two physical different departments, or it could be this end is recovery and this end is pre-op. But you have to separate those out because you don't want to put a clean patient with a dirty patient. Clean patients being a post-op patient to what we call a dirty patient that hasn't had surgery yet. So you can combine them. And there's a lot of times we will recommend that on the weekends, after hours, if you don't have a 24/7 PACU area, we'll say, okay, then maybe we can just separate out, but it has to be physically separated just to keep things safe and keep things not mixed. And the skill set is different. You can have a pre-op nurse that doesn't have an ICU background or doesn't have an ER background, and they are a highly functioning and highly competent pre-op nurse.
Yeah, what
Um,
makes a good
so
pre-op nurse? What should I be looking for if I'm trying to hire pre-op nurses?
as with anything, you want to make sure that they are very efficient, very smooth, critically thinking, because it can be a dynamic environment where you do have to be flexible and shift gears. So, good IV skills, because this is where we start IVs, and we don't always have the best veins available to us. Good IV skills is really critical. You want that good personability interaction with the patient because this is the patient's first step in the hospital's experience. So you want it to be positive, you want it to be good. And let's face it, no matter if you're a healthcare professional or not, having surgery is very scary, intimidating, and stressful. So you want that person that has that really good interaction with the patients, that calming, competent individual.
Any key metrics that I should be looking at if I'm a chief executive or a chief nurse and trying to understand that my pre-op department is running smoothly?
Yeah, so several key metrics, and these key metrics also overlap with the operating room. So when you look at these metrics that we're about to talk about, you might have to back up and look at the operating room flow because they are delicately intertwined at times. The first thing I would look at that is pre op completely driven is patient length of stay. How long are we having these patients in pre-op before they get to the operating room? That is a patient satisfier, and that is an indication of efficiencies and smoothness of the department. So that is pre-op driven, pre-op controlled, pre-op only metric. The other thing that we want to look at is your first case on time starts ratio. How much of those patients, what percentage of those patients are getting into that operating room at that surgical time, that scheduled surgical time? Very important to see how efficient things are running in there. If that number is super low, we like to see a good first case on time start rate, about 95%. So all those cases should be getting into that operating room on time or early. If that number is super low, is it a pre-op issue? Are processes in pre-op not good, not hardwired? Is pre-op tracking down paperwork the day of surgery, last minute diagnostics, all these things that maybe could have been done before the day of surgery? Or is it an OR readiness issue? Is that OR room not set up so we can't get that patient in there? Or is it a surgeon issue? We have a surgeon that is habitually late, never gets there on time. So you want to be able to drill down on the reasons for not getting those first cases in the room on time. So that's why I say you have to look at the big picture when you look at that, because it's not just an in siloed metric. The other one you want to look at is the turnaround time. And a lot of people think that turnaround time is an operating room only metric. It is not. And when I say turnaround time, I'm talking in the operating room, last patient leaving to next patient going in. What is that gap in between? And a lot of people look at that and think, okay, that's operating room, that's on them. It's cleaning up the room, setting up the room. But that's not necessarily the case. It can have a pre op influence because if pre op doesn't have that patient ready, then they can't get into the room, and that may make a prolonged turnaround time. So that's the other very crucial metric to look at. And again, you can't look at it in silos. You have to look at it from a macro level and drill down to the micro level to track and trend and really know where that friction is and where you need to mitigate it.
So I'm curious. We talked on the PACU episode about a call coverage overnight. What should happen for pre-op preparation for a case that needs to go emergently overnight? How do those patients get all of those steps of the pre-op process completed? And is there a leading practice out there? Do I need a pre-op nurse for this? Should it be the PACU nurse like you talked about that's going to come in and do the pre-op? Or do we just take them straight from the ER or straight from the unit that they're on and take them straight to surgery and the OR nurses are going to handle it?
Yeah. So again, it's highly variable on the facility. If it is an ER patient, most likely the OR team is going to come down to the ER, pre-op the patient there, and then take them straight into the operating room. And that's because usually the ER has put the IV in place, they've done the medication reconciliation, most of the diagnostics are done. The surgeon has probably been to the ER to evaluate the patient. So a lot of that pre-op work has been done by our ER colleagues. So most of the time, the OR staff, the OR nurse, and anesthesiologist will come to ER, do the pre-op there, and take him straight into the operating room. If it is an inpatient, After hours, that can go both ways. OR staff can go up to the floor, see the patient, do everything, and take them straight into the operating room. Or if you are a facility that has extended hours in pre-op, they can go through pre-op if it's an inpatient setting. And we're talking after hour only here. So yeah, it can be done both ways. It can either go through pre-op as a formal pre-op process, or the OR can go do it at the bedside and bring the patient straight into the operating room.
A lot of the discussions that we had earlier around key metrics were around efficiencies or lack thereof. Any key pearls of wisdom that you might have around streamlining processes in the pre-op areas?
I think the biggest influence or biggest indicator as to how smooth or how chaotic the pre-op flow is going to be is, we touched on it a minute ago, is that pre-admission testing, pre-surgical testing process. That is where you really want to review that patient's chart, the patient's medical history, do a screening and assessment, if you will, and try to get a lot of the diagnostics out of the way before the day of surgery. Any concerns have been escalated to either the surgeon or the anesthesiologist before the day of surgery. They're the ones that want to make sure all the paperwork is here. Do we have the consent? Do we have orders? Do we have an HMP? If you have a very well rounded pre optimization process, that day of surgery will be very smooth. So they go hand in hand. If you do not have a robust pre optimization process, I can guarantee you when I go into a facility, it's going to be some chaos on the day of surgery.
Any closing thoughts as we wrap up our episode?
Remember that pre-op is a three-legged stool: anesthesia, OR, and the surgeon. If one of those is not adhering to best practice recommendations, pre-op can be a less efficient process. And what we mean by that is you want to have, I always say it's a T minus countdown. If the patient arrives 60 minutes prior to the surgical start time, you want to have that nursing assessment done maybe at 45 minutes mark on that countdown clock. You want to have anesthesia in there at that 30-minute countdown clock. And you want to have the surgeon in there at that 15-minute countdown clock. So it's all sequentially mapped out. People aren't stumbling over each other. You're getting things done in a very smooth flow. And that also allows that nurse to get her assessment out of the way and then flow over and do another assessment while that anesthesiologist or CRNA is coming in and doing theirs. So really look at it from a T minus countdown in a sequential step of processes. And if you can hardwire that, your pre-op process and your pre-op flow is probably going to be very smooth.
Noreen, thank you so much for taking time today to talk all things of the preoperative department. Really appreciate your time.
Thank you, Nick. I appreciate your time as well.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.